I would love to show some data about the hypervolemia that is a common clinical cause for acute decompensated heart failure patients. Patients with fluid overload have twice their mortality compared to those without. And the most common intravenous medication is intravenous diuretics, not only in pulmonary edema, but interesting in cardiogenic shock. In patients with evidence of fluid overload, the usual initial intravenous bolus dose of furosemide is 20 to 40 milligram. If there is a little or no response, the dose should be doubled at 2 hours. The maximum intravenous dose should not exceed 240 milligrams per day. As a result of those tried, there is no significant efficacy and safety endpoints for bolus versus continuous infusion. So a continuous infusion should not be tried in patients who have not shown response to maximum intravenous bolus dose. However, hemodynamic congestion is not benign. Diuretics have not any effect on mortality and long-term quality of life. And there are many negative effects like reduced kidney function, activation of neurohormones, loss of electrolytes, reduced cardiac output, increased total systemic vascular resistance. So the question is renal replacement therapy better than diuretic? Theoretically, yes. Ultrafiltration allows for extracorporeal removal of plasma water from whole blood across a semipermeable membrane in response to transmemoral pressure gradient, and venous UFI can be performed via either central or peripheral vascular access as long as there are 2 catheters or 2 lumens that can provide 10 to 40 milliliters per minute of blood flow. There are many advantages for UF, for example, more rapid removal of fluid access. Ultrafiltration is isotonic, whereas the urinary output with loop diuretic is hypotonic. Higher clearance of sodium node, decreased risk of electrolyte abnormalities, worsening renal function, lack of activation of renin-angiotensin aldosterone and sympathetic nervous system, and removal of pro-inflammatory cytokines. However, patients with poor venous access, hypercoagulability status, hypotension, advanced renal disease, cardiogenic shock, and those requiring inotropic support are generally not suitable for this treatment. So, should ultrafiltration with these advantages be used for the initial treatment of heart failure patients? The first results of studies were positive. For example, rapid CHF showed dyspnea and heart failure symptoms were significantly improved in patients with UF. However, the median length of stay of hospitalization and white loss were similar. As the same in unload trial, white loss was greater in ultrafiltration than the standard care group, and UFI statistically reduced the heart failure, rehospitalization, and secondary endpoint. But the results of CARES-HF changed everything for ultrafiltration. In this study, UFI was investigated in patients with heart failure who have worsening renal failure and persistent congestion. In the UF group had higher serious adverse event. There was also no significant between group difference in white loss, mortality, or the rate of hospitalization. and there was significant increase in the serum creatinine level in the ultrafiltration group. So UF was inferior in the strategy of stepped pharmacological therapy in this population. What about the slow, continuous ultrafiltration? Is better than fast one? Unfortunately not. The speed significantly improved in hemodynamics. The overall 1-year cause of mortality was high. So in conclusion, for first part, intravenous furosemide acutely increase venous capacitance, which may be an important factor in real-life symptoms. Direct vasoactive effects of diuretic may play a role in the benefit obtained with pharmacological therapy. At the present time, based on the available data, ultrafiltration should be a patient therapeutic modality. We serve the second-line approach in diuretic refractory patients. So the best ultrafiltration in acute heart failure is still diuretics. And the also guideline recommends the loop diuretics as first-line therapy. When diuretics is inadequate, the authors consider to be able to enhance the diuretic regime using either higher dose or adding a second diuretic. Low-dose dopamine infusion added with class 2B, in addition to loop diuretic therapy to improve diuresis and better preserve renal function and renal blood flow. In the absence of hypotension, intravenous vasodilators still remain with a class 2 indication as an adjunctive to diuretic therapy for life of dyspnea in patient with acute decompensated heart failure. I have a few slides about the non-pharmacological strategies, such as sodium restriction is responsible for patients with symptomatic heart failure to reduce congestive symptoms. The restriction of sodium to 1.5 grams per day appears to be appropriate for most patients with stage A and B. However, for patients with stage C and D, currently there are insufficient data to endorse any specific level of sodium intake because sodium intake is typically high in general population. Clinicians should be considered some degree of sodium restriction in patients with stage C and D. Fluid restriction is responsible, especially patients with hyponatremia, to reduce congestive symptoms with evidence of class 2A. CPAP may be considered as adjunctive therapy for patients with high respiratory rate and persistent systemic arterial hypoxemia, despite high flow oxygen to relieve symptoms. However, routine use of non-invasive ventilation is not advisable. And for the last, ventricular assist devices are effective in short-term management of acute decompensated hemodynamic unstable, reduced ejection fraction. Patient had low cardiac index, low blood pressure, high pulmonary capillary wedge pressure, and despite adequate pharmacologic therapy and refractory to inotropic supports. Thank you very much for your attention.